Role of use of HFNC in the wards.
I think when I'm seeing all the questions, I probably have to give a separate lecture altogether. Most of the questions I think are directed to me. So the high flow nasal cannula in the wards, it's an interesting concept and in fact has been looked at, is it something which can be utilized in the ward settings? I think the concerns are, as I mentioned, is monitoring. Okay, we all saw that if a person is delayed intubation, there's a much higher chance of mortality. And hence, all across the world, a person who's on high flow nasal cannula is preferably monitored, at least in a high dependency unit, rather than the ward settings where you are short on staff. They've actually looked at cost effectiveness studies also in the role of HFNC in the wards, and they found that it is not really cost effective in the wards as compared to the ICU setting. So
We do the next one also. How is CMC's experience with ECMO? What are the common indications in our setup and the outcomes?
So we have, I wouldn't say that we are a high volume ECMO center. And I think most of the constraints that we have are with relation to cost. The circuit itself on day one would work out to at least 5 lakhs, which we all know a lot of our patients struggle to even pay their regular bills, and asking them to pay upfront a bill of 5 lakhs for circuit costs, that is a big expense on their part. So we have done ECMOs, but we have carefully chosen all our patients we've put on ECMOs. And by God's grace, I would say at least 80% of the patients we put on ECMO have actually done well. We started recently for retrieval for lung transplant that went on well, and hopefully in our center we may see more ECMOs being done, given that lung transplant and heart transplant has been approved for the Ranipet campus. So the numbers may go up in that setting. In the acute medical setting, I would say the problem is really the cost. And as I said, in fact, we're actually looking at, we are actually a high volume ARDS, severe ARDS center, where we manage most of our patients with mechanical ventilation and are pretty successful with it. And hence we hope to put out this data, to the rest of the world to show, could ventilation be an option also in these kind of situations. I think we use it only when we are pushed against the wall, not able to ventilate, not able to oxygenate. Those are the kind of scenarios where we have used ECMO in CMC. ECMO, I think the main role has been in patients with myocarditis, really not post CABG, though sometimes occasionally it does come up. But again, here, the same constraints of costs and the evidence which Dr. Krish has already presented.
Last question to Bidila. Is NIV useful in bronchial asthma? Why is there less evidence available in asthma versus COPD exacerbation?
I think that's a separate talk altogether. Okay, so in the sense that bronchial asthma, the pathophysiology of of type 2 respiratory failure is very different from what we see in COPD patients. So the evidence to support the role in an acute exacerbation of bronchial asthma, there's no role of NIV in that situation. I think we'll have to take a separate, completely different.
Yeah, thanks, Billa. I request Krishna Swami to answer the next two questions.
Yeah.
How long do patients typically require VV or VA ECMO before they recover? Is this a cost-effective treatment in a low middle income country like India?
Okay, so the question is, how long do these patients require to be on VV or VA ECMO, and is it a cost-effective intervention for a low to middle income country like India? Okay, so I'll take the first question first. So the time frame for VV and VA ECMO, it depends on the indication. Okay, so it depends on the etiology, it depends on the patient characteristics. So VV ECMO, we are looking at, a matter of days to weeks. That's how I would say it. Okay, so we have had patients who have been on VV ECMO for the longest we have had is up to 6 weeks. Okay, and the patient still recovered from their pathology. So it was a patient with severe necrotizing pneumonia who had a lot of cavitatory lung lesions and the lungs were just getting liquefied and losing volumes and essentially left with just one functioning lung. So it took a while for us to wean the patient of VV ECMO. Our experience also traces back to the swine flu epidemic. I'm not talking about the COVID pandemic, but the swine flu epidemic that happened in 2009, 2010 is when we first started doing VV ECMO. So in those days, we used to have patients for up to, a maximum of 2 to 3 weeks, but now we have gone up to 6 weeks as a maximum. So, but VA ECMO, usually in a matter of days, it's usually not going into weeks unless until you are waiting for a transplant, or you're waiting for a destination. So the problem with that is because it becomes unsustainable beyond that. And actually you have more problems than benefits, and you in fact create more complications. So, but the question about whether we can support that in a low to middle income country like India, look, I would consider like VV ECMO. I suppose if you're getting it for the right indication, then you're expecting a benefit in a matter of days to weeks, then probably yes. But VA ECMO, the evidence for that is not particularly strong. Okay, so I would be very careful about starting someone on VA ECMO. Whereas VV ECMO, if you have the right patient and then you're positive that the etiology is at rest. When I say the right patient, the right patient who got the right intervention at the right time in the right institution. So there are a lot of rights that needs to go with that, and also looked after with the right team right at the outset. So I can't see that purely the finances should be a constraint for VV ECMO, but VA ECMO, I would be very wary of starting it without due process and again for the right indication.
Thank you, Dr. Krishnaswamy. We'll take one final question. Recent publication in JAMA showed that NIV in comatose patients with acute poisoning, a conservative strategy of withholding intubation was associated with clinical benefits. This is contrary to the conventional thought that coma is a contraindication for NIV. What's your take on this?
Nice question. I think I would request whoever's put the question to go into the details of that trial. So this is a JAMA trial published in 2023, where it was interesting that NIV was used even for patients who had a GCS less than 8, which is usually that our traditional definition for criteria for intubation. But if you look at the toxins which were used in that study, about 75% were a mix of, or maybe close to 80% were a mix of alcohol, benzodiazepines, and opioids, all of which are quickly reversible and have got, antidotes. So in the sense that in that situation, it's made a difference. Now, will our opioid poisonings or will our other patients be able to manage with NIV? I would say questionable. We had to look at the clinical scenario. So in that study, predominant group of patients these were the poisons for which you can give an antidote. They usually will wake up, and most of them are protecting their airway. The issue is, are they protecting their airway or not? If they are, you can wait, sit tight, wait for the antidote to act.
So it's not generalizable. We can't.
Not generalizable. That study is not generalizable to our group of patients.
That brings us to the end of our session on critical care. Thank you very much to our speakers and chairpersons for an informative and engaging